Hello, and welcome everybody. Thank you for taking the time today to join us for our special event on National Rural Health Day. I'm Ashley Munninger, and I'm the Communications Director for the National Organization of State Offices of Rural Health. NOSOR is proud to have founded National Rural Health Day clear back in 2011. And we've celebrated the power of rural on the third Thursday of November ever since. Over the next hour, you'll hear from 3 rural champions, each of them speaking on successful rural health strategies at the local, state, and national levels. As we go, feel free to submit any questions you have in the chat box. We will try to address as many questions as we can at the end of the webinar as time permits. This webinar is being recorded, so you'll be able to find the recording and the slides on the powerofrural.org website in the coming days. Now, I'm delighted to introduce you to today's guests who will talk about their incredible work to advance rural health. First up is Diane Hall, a longtime friend and supporter of NOSOR and the director of the brand new CDC Office of Rural Health. We're also joined by Eva Cruz of the Texas State Office of Rural Health and Fern Christian from the Virginia State Office of Rural Health. Both state offices received funding in 2021 from the CDC as part of the COVID-19 Health Disparities Grant Program. Eva and Fern will share some of their successes from their work through this funding initiative. So without further ado, let's get started. So here's Diane.
Happy National Rural Health Day, everyone. I am so excited about today. I'm excited about a lot of things, but I just wanted to say that it's been really great being here in North Carolina. So I'd like to take a few minutes to talk with you a little bit about CDC's Office of Rural Health, established in 2023. So we're not even a year old yet. So essentially, the idea behind the Office of Rural Health is not that we will be creating a separate center that focuses on different topics that CDC covers, such as injury or chronic disease prevention or things like that. We already have experts in those different areas. The idea is that CDC's Office of Rural Health will work across the rest of the agency and work with those experts in the work they're already doing, but to address rurality better. Rural can be a complex and nuanced landscape, and our goal is to help our colleagues across the agency better address rurality. So when we think about the work that we do here at CDC, we often think about it in terms of these pillars. So research and data, communication, program, and policy. And the idea is that the Office of Rural Health will provide capacity building support across those pillars. We will be doing cross-agency coordination, which we've been doing since 2017, but now we'll be able to do more of it. We'll continue to do strategic engagement and partnership and hopefully be able to expand those partnerships and then provide some leadership for rural public health. So I want to talk a little bit about some of the principles of the office. I'm actually going to start at the bottom on this slide in the middle, that weird beigeish color. Examine variability. So the idea here is that the narrative about rural cannot be that when we look at rural and non-rural data, that rural is lagging on whatever indicator we're looking at, because that's pretty much going to be the case for most of the things that we would be examining. That's not helpful. It's not empowering, but the bigger issue for me is that it's also not accurate. When we look at that variation within rural, this is where we start to see differences by age or by region or by state or by race and ethnicity or gender. And this is also where we can find areas of strength. Rural communities are doing amazing, creative, innovative work. And I'm so happy when I can visit rural communities and learn more about the fabulous work that's happening. So when we start to examine that variability, we get better data and better information about how to actually address any challenges that we're seeing. It also allows us to find those strengths and focus on those. And then CDC is in a position to then amplify that work, champion it, and disseminate best practices. I always say that in public health, we have to collaborate with partners. I think that's especially true in rural public health. And when I say partners, I mean all sorts of partners, not just those that might work in, traditional health fields. So we're talking about housing and transportation and early child education and things like that. In public health, all of those are related to the health of people. So focusing on strengths, I do have an example. I'm not going to go into all of those, but this example is from COVID. And I was working with the vaccine task force, and we were looking at our national immunization survey data. And I just said, hey, are there counties, we were looking at counties, are there counties that have COVID vaccination rates higher than we might think? And lo and behold, there were quite a few rural counties that had COVID vaccination rates that were higher than their state, which was not the trend that we were seeing when we were only looking at that national picture. So we worked with NORC and East Tennessee State University on a qualitative study to better understand the factors that were influencing that vaccine confidence, looking at social media data. And we identified 6 rural communities and did interviews with key partners in those communities to develop 6 case studies that are available on NORC's website. We also have a summary of that. This work I thought was incredibly important because this was bucking the trend. This was an important additional story to tell. The story with the national data was that rural was behind, but that wasn't true, not for all communities. One of the things that I think was particularly poignant was that when NORC and East Tennessee State University first reached out to these communities, they thought they were doing something wrong. It didn't occur to them that they were doing something right. And I think that's sad, and I would love to see that reverse and not be a thing anymore. So championing the work, so Ashley mentioned the health equity funding. I am so proud of the rural carve out that was a part of this health equity funding. This was part of funding that CDC received during the pandemic. Essentially, CDC indicated in the funding announcement that the state health department was required to work with the State Office of Rural Health, and that a certain percentage of the funding needed to go to rural communities. And we calculated that percentage and told states how much money needed to go to rural. So we worked with the Federal Office of Rural Health Policy, just talking through some different options for funding formulas. And I have to tell you, and I'm probably preaching to the choir here, this was a big deal when this funding announcement was published. I received a lot of emails, just people were so excited that CDC was demonstrating that we were serious about rural health and serious about that equity. So part of what this really unattractive slide is also trying to get across is that CDC does have a portal to collect success stories, and anyone who is a part of this funding can submit a success story. You don't have to subscribe, you don't have to be, approved in the system to submit it. But the expiration date is January 31st, 2024, and I'm assuming that is an OMB thing more than anything else. Part of what the Office of Rural Health is going to be doing is adding additional funds to the evaluation of this funding initiative so that we can better tell the story of this rural carve-out. We're interested in hearing what was going on at the state level, but also what was happening locally. We want to hear those stories of innovation. But the other thing is that as I've traveled, I've heard from some states that things look different for them now as a result of this funding initiative. So I've heard from Connecticut and Montana that they're now included in state level conversations as a result of having participated in this funding initiative. And that had not been happening before. And to me, that's really critical and important systems change. You have to have a seat at the table. And so, as I said, this is work that I'm very proud of. We had a great team that put this together. So if you haven't submitted a success story, please do so. Collaborating with partners, I won't talk a lot about this, but we work with federal government. Obviously, I would say the Federal Office of Rural Health Policy at HRSA is probably our main partner. But USDA Rural Development has some staff that are working with HHS. There's a funded position there now, Kelly Cabina. is the liaison there, and just USDA is doing a lot more in the health space. And of course, that's where 4-H is, that's the extension, and those are really critical partners to achieving change in rural communities. So we have regular contact now with USDA because of that position. Obviously at CDC, we work in public health, so with ASTO and NACHO. We also obviously work with NOSOR. We're a huge fan of NOSOR. When I consult with anyone across the agency and they say they want to do something in rural, my first question is, have you checked with your state office of rural health? Did you know that every state has a state office of rural health? Because the state offices have just been amazing partners and were so important to our rural COVID response. And then we also sometimes work with population-specific groups. So the National Center for Farm Worker Health is a good example. That was a really important partner when we were doing COVID vaccination drives. That was a population that was going to be challenging to reach in some cases. And so working with that partner was absolutely vital. I have to talk about some resources. So the first is a Rural Emergency Preparedness and Response Toolkit. We launched this a year ago. So we worked with RHI Hub. And essentially the story behind this is that we were doing rural partner calls early in the pandemic. And one of the things that CDC was saying was check with your state emergency folks to find out what your emergency plan is. And a lot of rural partners didn't know about that and weren't quite sure how to do that. So I did what I always do. I went to RHI Hub because that's where you go first to find things. And I love those evidence-based toolkits, and they didn't have one yet for this. So CDC worked with HRSA to fund development of this kit. And if you haven't seen it yet, it's amazing. There's some fabulous real-world stories in there. And it's not just for pandemics, it's for any type of emergency. The second resource is the Rural Health Mapping Tool. So we worked with NORC and ETSU on this. That might look familiar to those of you who saw the opioid mapping tool that NORC did. I'm a fan of that also, and I knew that that platform could be used for any type of publicly available county level data. And so when we received funding to do some work in COVID, I thought, well, let's create something that's going to last past this emergency. That's true for both of these. And so for that rural health mapping tool, you can click on your county and change the variables, and you can see how your county's data looks compared to your state and compared to the country. There are different overlays. There are social determinants variables in here. There's a prosperity index that includes risk and resilience factors, which is really nice. So everything is right there at your fingertips. We are in the process of bringing that in-house to CDC, but we'll have a redirect on that. And that's it for me. If you need to reach me, you can email me directly, dmhall@cdc.gov, or if you forget that, ruralhealth@cdc.gov should be really easy to remember. And with that, I would like to turn it over to Eva Cruz, and I will stop sharing.
Thank you, Diane. Here I am. There's my camera. It came on. It wasn't working a little while ago. So, good afternoon, everyone, and happy National Rural Health Day. My name is Eva Cruz, and I'm with the Texas State Office of Rural Health. I am the project lead for this community paramedicine pilot project here in Texas. We have this grant. We partnered with, actually, it's a pass-through grant with the Department of State Health Services, and we partner with them, and they're a great partner because we work together really well. So our pilot consists of 5 counties in the Texas Panhandle. If you can move the slide. And so here you can see that where these counties actually are in the Panhandle of Texas. There's 4 on the, of course, on these 4 corners. This county, Lynn County, we just added recently. The other 4 were originally part of the pilot project, and since we extended the project and had funding available, we extended it out to another community. You'll move up, Beth. Okay, so the purpose of the community paramedicine project is to engage the communities about the benefits of having a paramedicine program in their community. And this means working with their county leaders and city leaders and all the medical community staff to make it a success. Your city and county leaders, it's important that they are aware of the project and they know what's going on for sustainability purposes after the grant ends. They will know that it's very beneficial to their communities and continue to do what they can to sustain the project. Training the EMS systems are trained. We have a trainer that we contract with, and they are to improve their skills and knowledge about community paramedicine. There are also a lot of other things that they receive training on, one of them being reporting, collecting all the data that they need to collect for this project, and giving them the tools to do that. The funding provides resources and supplies that are needed for their vehicles and to provide care to their residents that are out in the communities. That some of those resources and supplies, those include laptops, cell phones that they might need in their remote areas to report and communicate in some of those remote areas. To increase the vaccine input in the rural communities and uptake. This is to, of course, let people know about the vaccine, the benefits of having vaccines. Some of these communities have had disinformation, so part of the project is to provide them with accurate information about vaccines and the benefits of having a vaccine and how that can prevent a hospital visit. To develop strategies to increase rural access to healthcare and decrease costs. The communities work well with their medical community, and they work together to develop processes on how they were going to put one of these programs in place. They usually are already working together in doing some of this work. It just wasn't being recorded. But we have found that in these small areas or these remote areas, everyone knows everyone and they work together, helping each other. To reduce the severity of comorbid health conditions. This is also part of the project, and one of the things that our communities are doing to reduce the severity of these conditions is through education and providing education about those chronic diseases such as high blood pressure and diabetes being prevalent in most rural communities. And so they provide education for them on how to prevent it or at least not let it get worse. FAST is another grant that we were able to obtain, and we worked with the Community Development Block Grant. It's a Community Development Block Grant funding. This is separate from CDC. This is through our Trade and Business Development unit here at the State Office of Rural Health and Texas Department of Agriculture. And this fund provides fire, ambulance, and service trucks to communities. They were able to help us purchase vehicles for the Community Paramedicine Project. So when we began, we had a total of 8 vehicles, and some of those communities received 2 vehicles, and then others received 1, just based on their populations and the level of patients that they had. So I'm going to talk now about our project and highlight some of the things that this project has been able to do. So there are we have 2 hospital-based EMS programs and 3 volunteer programs. So the Community Paramedicine Project that I'm going to talk about is a hospital-based project, and it's in Deb Smith County, which is in Hereford, Texas. It was one of those rural communities you saw there. It is a very big area. It's very vast. So they cover a lot of mileage on their vehicles. They go a long way, and they work at this full time. There are 2 full-time staff that are dedicated to this project, the EMS director, and they have a hospital social worker. And they go out on calls on visits together. And I think that works really well. If if you have that resource available as a social worker, it really helps. It helps a lot in developing trust in the community. And most of the times, these patients already have some um, interaction with them. So it's very important if you're able to have a social worker uh, on staff with you. So they participate in discharge planning every day, and they follow the patients after discharge. Usually they make a visit the same day. They want to be sure that the patient understands the instructions given to them at the point of discharge, because sometimes when you're being discharged from the hospital, you've got so much stuff going on that you think you remember everything, but sometimes you really don't. So they go out and make sure that they receive the instructions correctly, that they follow the instructions correctly, that they have their medication, and have access to purchase more medication if needed. They train them on how to take that medication. They train them on how to check if it's a diabetic patient, how to monitor your blood pressure, or your glucose levels, how to record it. The same with blood pressure. They teach them how to um, monitor their blood pressure, keep a log of it. Um, no, I'm sorry, there's not another slide on the screen. I saw that question there. I'm just sorry about that. They educate them on nutrition, how to prepare their foods, their diets, to help prevent some of these diseases from getting worse. Uninsured patients are screened and applications are made to assistance programs that they are potentially eligible for. And this is something that the social worker does once she's out there as well. She screens them for any kind of programs that they might be eligible for. And once their visit is complete, the assessment is scanned into the patient chart for providers to have access to and be aware of the services provided. This way, that provides a continuity of care. Everyone who has seen the patient has recorded what services they provided to that patient, and everyone knows what's going on with that patient. Another part of what they do is they do an assessment of the patient's home. They assess for safety. We've had some where someone was in a wheelchair and they needed a ramp. That's where the referrals comes in. If someone is needing a ramp, we have different organizations that might be able to help with that based on their situation. If it's an elderly person, then we refer to the Department of Aging and Disability, so that they can try to get them get their home to be a safe place for them. Other things that they've seen or had to speak on is about rugs. That's really can prevent falls. Sometimes the rug can be curled up and they might have an accident, and so they kind of just make an assessment and make recommendations to the patient on how to better prevent some of those falls and prevent some of those hospital readmissions as well by keeping their glucose levels and blood pressure checked and those kind of things. We also have 3 volunteer programs, volunteer EMS. Those programs, they provide the same service. It's a little bit different for them. It might be a little more challenging because, of course, they are volunteers. It's hard for them sometimes to follow a patient home directly after discharge, mainly because they're probably at another job or the appointments just don't line up. So they try to get out there as soon as possible after discharge. It may or may not be the same day, but for them, most of the time it is not. And they're not full-time, so that's another reason why they don't do that. They also receive referrals from the clinic for patients because they're not involved in the day-to-day happenings at the hospital. So they receive referrals from their rural health clinic or it can be other medical providers as well. And they get referrals much like a referral to a specialist. Their systems, the hospital systems, put them on as a referral source, and they get that referral. They do the same thing. A report is made, and it's sent back to the referring physician or referring agency, so that everyone again knows what's going on with the patient. This project has proven to be a most effective way to provide education and healthcare to rural residents that otherwise might not have received it. This project also addresses a lot of different things. I think it addresses quality and reducing hospital readmissions, financial and reducing the hospital readmissions, and also for the ambulance, the EMS as well. It might reduce the unnecessary ambulance calls that they make, because of course have educated the person not to call an ambulance or when to call an ambulance, and a lot of the times they call them first, and that's basically what this project and part of it is, to kind of reduce those kind of calls that are unnecessary or that could avoid an ED visit. Most of the populations here, of course, in rural areas are elderly. They're an elderly population. And so addressing some of these comorbidities by educating them on chronic illnesses and providing the tools to monitor their care is essential. So the program does provide, can provide glucometers or blood pressure cuffs. They do address some COPD challenges and methods that they could use to kind of prevent that. Not prevent it, it's not going to prevent it, it's already there, but to reduce that disease. I think this is a really valuable project for the communities, and any community that actually wants to have a project like this or start a project like this, I think is very beneficial. I think it would be very accepted in any community. We do have a lot of other requests to increase or to go into other communities, but right now we're just not able to do that due to the grant period is already, we did have a no cost extension until May of 2024, so we were able to increase the project another year. We have an evaluator on our project, and he will be doing an evaluation about the project once it's done. And we really look forward to seeing that evaluation and sharing it with everyone to see how valuable the project was and how what a success the project was. It's already a success because we have provided care to people who otherwise wouldn't have gotten care. So it is already a success for us. So thank you very much for inviting me to share information about our project. And I think Ashley put my contact information in the chat in case any of you have any questions or just want to talk about possibly starting a project, and we can share all the lessons learned and all the bumps along the way and the challenges we encountered, because it seems like it might have been an easy thing to do, but when it's a project just getting off the ground, there's a lot of things that I didn't realize were going to be needed, and just little things, but now it's running smoothly and we can see the work that's being done and the care that's being provided, and our medical staff in the rural communities and the EMS services are very passionate about their work, and you can just see that they wouldn't be doing this if they were not. So I encourage you to think about doing something like this if you can. And again, like I said, if you have any questions or just want to talk about other things that we did or encountered, we're glad to share. We're glad to share that experience. And so now I'm going to hand it over to Fern. think Fern has a project that she was working on this as well. Not just like mine, something different. So Fern, there you go.
Thanks, Eva. Good afternoon, everyone, and happy National Rural Health Day. My name is Fran Christian, and I am the program lead for Virginia's Rural Response and Relief Program, which is funded by the CDC Health Disparities Grant. So today I'd like to just talk a little bit about our state strategies for not only spending down grant funds, but also engaging and improving our rural communities. Next slide. So the Virginia SOAR houses many other programs, but this one, as we know, preaching to the choir again, is very unique in its ability to target the impacts of COVID in rural communities. Within our strategies, we knew from the beginning that focusing on our rural districts was the best approach. That being said, Virginia is a larger state than that meets the eye, with the trip from the tip of our most northern county of Loudoun to the edge of our most southwestern county, Lee, taking approximately 6 to 7 hours. With these differences come areas where some counties are surrounded or lined by metropolitan cities and have different needs than other areas that are far more rural. Next slide. So keeping this in mind, we knew that it was critical to focus on the 3 strategies listed when developing our state strategies in order to effectively communicate this great opportunity. First was connecting with organizations or local health districts that have conducted their community health needs assessment to identify those specific challenges and opportunities. We chose a boots on the ground approach, which included our quarterly meetings, in-person meetings to our 18 rural local health districts to just better understand their needs while also adding depth to those communication, to the communication, which allowed us to lead to better insights and solutions. Secondly, we met with local leaders as well as organizations to better understand their needs firsthand. Understanding the needs of each rural area while also collaborating with other local organizations provided us with the tools we needed to really determine which disparities should be addressed and how. And lastly, with the help of our rural health districts, partnering with our community organizations, assisting us in developing those projects and programs based on those unique characteristics and the needs of each rural community. I'll go into a little bit more detail as I continue, but this allowed us to essentially be in 2 places at one time and expand our work in the rural communities without depleting our existing infrastructure. Next slide. So we wanted to really find a way to increase and maintain communications with those districts while also providing an open discussion channel to address those important grant topics as well as in between our in-person meetings. So we decided to host a monthly roundtable to facilitate those open discussions, share successes, and really just collaborate to address those challenges among our districts. This really helped us to promote transparency, align our district leaders with the grant goals, as well as provide any major updates. Next slide. So in addition to our monthly roundtables, we also decided to offer our community partners in districts something a little bit different. We implemented a self-service booking for technical assistance, and this allowed us to provide support and enhance the skills while also offering hands-on guidance to improve those processes. This allowed our districts and our grantees to address those challenges, ensuring compliance and building capacity. Overall, this helped us to foster longer lasting relationships within our rural communities. Next slide. So to date, our rural districts have participated in over 80 programs since this grant was awarded. You can kind of see them in the strategy it falls under, but 21 was aimed at building and expanding infrastructure, 9 aimed at increasing and improving that data and collection, 22 for mobilizing community partners, and 29 at expanding and developing mitigation and prevention resources. Next slide. So some of these funding activities included educating over 120 community members to improve our public health infrastructure, as well as educating and training 327 community members in Narcan and Rapid Revive. To date, over 20 community health workers were trained, hired, and deployed to assist in Virginia rural areas, and over 16,000 COVID-19 mitigation and prevention resources were distributed. Next slide. So as our districts continue to advance health equity, I wanted to spotlight just a few projects that they have done outstanding work with the CDC grant. First, I wanted to highlight our Cradle Health District, which adopted a tobacco association project. This project engaged 3 local partners, including their Central Virginia Health Services, their public school system, and then the local Boys and Girls Club. Through multiple team focus groups and tobacco association initiatives, this promoted tobacco, nicotine, and vaping cessation among youth in the community, which overall achieved the goal of educating youth about the hazards of tobacco and nicotine. Another groundbreaking initiative or fantastic initiative that was completed by another health district of ours, West Piedmont, was a project focusing on increasing data collection and reporting, in which they collaborated with Virginia Tech College here in Virginia to boost community outreach, as well as truly engage those hard to reach rural areas that include those crucial populations. Next slide. So to highlight some of the wonderful partnerships forged by our district to date, more than 1,900 partnerships were mobilized. As you can see in the pie chart below, I won't go into too much detail, but most of these partnerships, or more than half, was new partnerships, which is great, with the remaining falling in existing partnerships and the expanded partnerships. But based on this data, we were able to conclude that the majority of these partnerships were with community-based organizations, with the next categories being faith-based organizations and community leaders. Next slide. So before discussing the impact of our third strategy, I'd like to provide a brief overview of the carve-out. So approximately 4.5 million was set aside for the rural carve-out in rural communities. And these funds were further divided by local health district, with each district receiving $255,000 in funding. With the amazing work that our districts were doing, additional funding increased our rural allocation to a little under 6.4 million. And approximately 1.4 million was set aside for SOAR CDC mini grant program, which I will discuss more in the following slides. Next slide. So our CDC mini grant program was established last year with the goal of sponsoring a variety of initiatives that matched any of the 4 strategies selected by the COVID Health Disparities Grant. Our first primary goal of the CDC mini grant program was just to include partnering with rural districts to support them in addressing the secondary and tertiary effects of COVID, as well as any other relevant health inequities within rural communities. The second goal is to promote rural community relations by assisting our districts in developing those connections with community organizations that share similar objectives. Next slide. So our mini grant program has 20 programs in 4 participating districts. They're listed below, and I have listed the number of partnerships and other programs mobilized by each district through this initiative. As you can see, New River has over 10, whereas Central Shenandoah has 3, and we even have some that have 1. Next slide. So I have also included all of our mini grant programs. I won't take up your time reading them all, but as you can see, many of them address COVID-19 secondary and tertiary impacts, including food security, housing security, mental health, wellness, health literacy, and resources. I'd also like to highlight that many of these organizations provide transportation assistance, maternity and child resources, as well as promote general well-being. Below, you can also see which category the programs fall into and how many belong to numerous categories just by offering and providing diverse services. Next slide. So today we're delighted to share that the CDC mini grant program has benefited over 6,000 families and individuals. The principal service location was at the organization's base, with the next two major categories being in the homes of community members and virtual. Furthermore, seniors were the largest group served, with veterans, youth, and teens falling very close behind. Next slide. So I did want to take a little bit of time out and highlight 3 programs from our cohort that is completing groundbreaking work within our rural communities. First is the Community Foundation of Central Blue Ridge, which utilized their funding to reestablish their emergency warm shelter. During the months of the warm shelter, the Community Foundation supported the most vulnerable community members during the winter months. In addition to this shelter, they also launched a photography campaign called This Is Home, as well as creating a housing summit that will provide an opportunity for their local leaders to work together to successfully address those challenges while also meeting the needs of their community. I've included some pictures from this campaign below, but they also have an online exhibit, and I'll be more than happy to put that in the chat after my presentation. Next slide. I also wanted to highlight Heroes Bridge. Heroes Bridge is a very, very interesting project. To note, Virginia has the second highest concentrations of veterans in any state with 9.7% of the population. This organization utilized grant funding to extend its community health worker program in order to address those socioeconomic concerns that older veterans are more likely to face, such as malnutrition, multiple conditions, poor income, and internet access. This kind of care assesses the patient's quality of life before providing in-home direct assistance. They have a battle buddy program, which pairs seniors with community health workers who share like interests and experiences in military service. They also help seniors with food preparation, transportation to appointments, immunization, education, and access to other health resources. Next slide. And then lastly, I wanted to also highlight another grantee from this cohort, Literacy Volunteers of New River Valley, who launched their Be Well Wellness for English Language Learners Health Literacy Program. This program's mission is really just to foster, support, and instruct adults in the New River Valley of Virginia who seek opportunities to achieve greater independence through literacy. Those services are offered to improve basic skills to achieve personal employment and civic goals through the instruction of reading, writing, math, GED, English language learners, speakers, and the U.S. citizenship test preparation, along with many others, and more importantly, health literacy. So overall, these strategies and the state strategies we've been able to implement really and truly has allowed us to connect with our rural health districts on a different level, as well as build long-lasting relationships that extend beyond this grant. So on behalf of our SOAR, Virginia SOAR, we'd like to thank NorthSOAR for having us to present. And again, happy National Rural Health Day. I'll be here to take any questions.
Thank you, Fern, and thank you, Eva and Diane, for your great presentations. We have about 15 minutes left, so we'd like to open up this time for any questions you may have for any of the presenters. So if you have a question, please submit it in the chat and we'll get to as many as we can. We do have one question already. What is family literacy?
Family literacy, I think this program really targets family literacy in the way that it is able to provide those services to a family. This program specifically focuses on adults, but I think family literacy is the idea that they're able to provide these services to all members of the family while also increasing the health literacy of that particular family, with focusing on one person who's able to help that family.
Great, thanks, Fern. Another question, how do we integrate these programs as private business owners? Judith, was that question directed to any particular presenter? Eva, were you going to take that one? Or
Yeah, I
Fern?
was going to say that as far as, I mean, I don't know what type of business owner they're speaking about, but if it's a private owned ambulance service or EMS, you know, some of them are private, they could partner with their hospital or, you know, one of their clinics to do a similar project.
Okay. We had another question up here. About resources. Are there resources that can be provided to us so that we can engage with our community?
Um, Ashley,
Yep.
we probably do have some resources that can be provided. We have some stories from our hospitals. We can provide some of that, how they, or some of our communities on how they um, started their projects and some of the things that they've done in their communities. If that's what they're looking for, I'm guessing that's.
Yeah, and we're happy to. So when we'll post the recording and the slides from the webinar, and we can also include on the page some other resources from the presenters, if that's helpful. We could collect a few to put on there as well. Okay, here's another question. Have your state offices of rural health been able to tap into any resources within your states, such as state government or foundation funding, to sustain these initiatives? Eva or Fern, any ideas there?
Let's see. We have not yet. I'll say yet.
I also have to agree, Eva. We have not just to sustain these specific initiatives. Um, and I see other questions for Virginia. Did our team fund any activities on the Eastern Shore of Virginia? Not with this funding. It is possible that that specific district, Eastern Shore District, has did different projects. I do believe they did a project with AEDs, and funding them in public spaces. And do we have any other plans to showcase the great work happening in the state? Um, I hope so. Yes. So we hope to continue to share this knowledge and the resources and how we implemented these state strategies. I really think that the boots on the ground approach really gave us the resources that we needed. All of our resources really came from our districts and getting their input into them being community experts in their own rural areas. So that allowed us to really work as a unit with them to figure out the best approach when addressing these different disparities.
And this is Diane. I want to put a plug in again for the success story portal. That would be a great place to share what you've done in your state with the health equity funding. And in terms of the question of sustainability, I think that could be something important we could look at as part of our evaluation of the rural carve-out part of this initiative. So I've made a note to double check to make sure that that is included. I do know some states have done some things, but I think if we could gather that information more systematically, that could be really informative for other states.
Great. There's another question asking how someone can find out about other initiatives and organizations, things that are happening in different states.
I'm going to say what I always say. This is Diane again. Check with the State Office of Rural Health in those states that are listed. If they don't know directly, they probably know who to talk to.
And I see a few raised hands. If you have your hand raised, if you could put your question in the chat, that would be helpful. Thanks. Okay, any other questions? Okay. I'm not seeing any other questions. Of course, feel free to reach out to us if you have some questions you think of later that didn't get answered or just want to connect with any of today's presenters. Um, Thank you again for your time today and joining our webinar. I hope you've been able to take a little bit of time out of your day today to celebrate the power of rural and thank those rural health heroes in your state or community or across the country that are doing really great work. You'll see on the screen there, if you click on that QR code, you can go meet NOSOR's 2023 Community Stars. We're featuring 39 stars across 39 states this year, all doing excellent work in advancing rural health. So we hope you take a time to read their really inspiring stories. With that, we'll close the webinar. Thanks again and happy National Rural Health Day.